Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival. It's critical to be radical.
Hello and welcome to this edition of For Health's Sake. I'm Charles Alessi, Chief Clinical Officer for Edito Health, and I am joined today by Liz Ashall Payne, who is the founding Chief Executive of ORCHA. And today we're talking everything about digital health regulation, digital health applications, and this wonderful new world we're in. But before I start, Liz, delighted to have you here. And one other thing, not everybody perhaps knows what ORCHA is. Could you just elaborate a little bit on that?
Yeah, of course. So delighted to also be here with you, and thank you for taking the time to talk with me. So as you said, my name's Liz and I'm the founding chief exec at ORCHA. My background, similar to you, Charles, clinical, but I've also led and coordinated transformational change at system level, both in the UK, across Europe and America. And ORCHA is absolutely obsessed with the power of digital health. And our mission is to improve lives and health outcomes through high quality, safe, effective digital health technologies, predominantly apps, but not just apps, also web-based technologies. Now, in order to do that job, ORCHA do a number of different things, two things predominantly. The first thing is we assure for these technologies. So we assess and evaluate digital health technologies. We're looking at all the things that you would expect around data security, data privacy, clinical, professional assurance, efficacy, safety, etc. And we're doing that repeatedly to make sure that we know what is safe today and, really importantly, who it's effective for. The other thing that we do is then we're obsessed with activating people to then use these trusted, effective technologies. So we work with healthcare systems, providers and payers to work on distribution channels. So creating digital health libraries that the population can access and find great, safe technologies. And then also working with healthcare professionals in healthcare systems, training people so that they now know about this new world, and then enabling them through digital health formularies to pick, filter and recommend technologies to their patients at a point of contact in the pathway. But our overall aim is not to review and assess. Our overall aim is to improve health outcomes.
So now you know exactly why it was so important for me to have a conversation with you today, because in essence, you're touching on the sweet spot which Edito Health has around the human aspects of deployment of technology, as well as the technology itself. I'm just always have been fascinated, Liz, by the fact that you assure health applications and systems to a degree, not systems really, but web-based systems,
Absolutely.
digital health in general.
Yes.
That assurance, and I've always thought it's really good we have an entity that's doing an element of assurance and thinking what the alternatives to an entity which is an independent entity doing that, as against, say, a governmental entity or a trade-based entity. And I think there's an issue here of credibility, perhaps. And also, of course, we know that state systems aren't necessarily the best at assuring sometimes. What's your sense of this dilemma? Because I'm sure you get asked
Oh, 100%. I mean, what ORCHA do on the Assure side is quite unusual for the private sector to lead. Now, as I've said, our mission and my personal mission has always been about improving health outcomes. And I saw digital health as a real opportunity to do that, if only we knew which technologies were safe and effective and we could deploy them to those people. So I got really obsessed with the problem rather than the solution. Of course, assuring, assessing, and knowing which technologies are safe is part of that jigsaw puzzle in that journey. Now, when we first started nearly 9 years ago, there was nobody there wasn't even really any standards or compliance criteria. So at that point, we said, okay, well, we're going to have to look at this. So we worked with regulators, we worked with academia, we worked with healthcare systems to build some criteria by which we could assess so that we knew which technologies could be trusted so we could get on with distributing them. Now, over the journey over the last 9 years, you've started to see lots of criteria emerge, and governments, particularly, or government bodies, have started to create digital health assessment frameworks or criteria. And that's great news because they then become the equivalent of a scheme owner. So they create this criteria. Now, what we then do is we say, brilliant, thank you so much. We'll now assess to that criteria. And what we're seeing, which is even more beneficial, is that different countries are learning from each other. And so what we're obsessed with is helping those countries to not spend tons of money and tons of time assessing, that they invest that money in the distribution and the activation. And then what we can do is we can passport the compliance data because a lot of the criteria is the same.
Yeah.
So we do still have some challenge around the fact that we're not a government body. I think when you ask about credibility, the first thing is we're open, transparent. All the questions, all the criteria that we ask are open source. You can't own criteria, and the processes that we go through are out there in the public domain. The second thing is we have asked people actively to go through our processes and to interrogate them. So regulators, we've asked them to go through it. And then, of course, when we work with a government body who ask us to do that job on their behalf, they also do the due diligence. So I suppose our credibility is built out of practice, and transparency, and collaboration.
Yeah, because let's go back a little, Liz, because the whole area of regulation of digital health is not necessarily a very nice story. I have to be frank and say that it isn't a very nice story, because we started with a really quite, I thought, a really quite odd way of delivering regulated digital health applications, certainly in Europe, through the EDD process, which I thought was always a bit strange. Now, of course, we have a different model, which we're trying to introduce, but wow, talk about a strangled birth, and also talk about a strangled birth that keeps on getting delayed. I mean, if this mother was pregnant, I think she'd have a pregnancy of about 9 years, not 9 months.
Yeah. I mean, I think that some of the challenges are that assessing and evaluating digital health has been viewed as a wicked problem. And the reason it's a wicked problem
is
because if you go back pre-digital, everything was hardware. And everything is an item that doesn't change. Whereas in the world of digital health, the technology changes, but also there's such a difference in the range of technologies and digital health technologies out there. And so it becomes a wicked problem by which you can't have one set of criteria. It has to be proportionate, but it also has to be agile enough to follow the way in which that product changes over time. You know, over the last 9 years ago, there was no AI. Well, now we're seeing AI, so which is really exciting, but brings with it a risk. So I think
big risk. This is a big risk.
Yeah, and I think that that's probably why this lady's still pregnant, because of course, you know, my background is the healthcare sector, and of course, being risk averse is part of that job. You have to manage risk. But of course, what we've been able to do, and I probably would say that we've been fortunate in that we were born as a private company, is we've been able to be agile in our thinking and think about the wicked problem in a different way. And that different way is about using technology to enable us to do that job at pace and scale repeatedly and proportionately. So it is a wicked problem. And of course, I love sharing how to deal with that wicked problem. And I think that we probably can learn from each other in that respect.
Oh, I think we can, but let's be fair to the health systems here and the regulators, because given that the regulators which were entrusted with actually managing this process were drug regulators, all one has to do is look at what the criteria for the regulation of a therapeutic agent is.
Yeah.
Something has to be the same, constant, give exactly the same result and effect whenever you take it in time. You know, constancy goes all the way through it. Now, you look to the new world where, if it is constant, what the hell is the advantage of having any sort of element of learning? Because it's going to be as bad or as good as it was on day one as it is on day 365.
Well, exactly. And the thing is that's really interesting when we think about digital health is how we use it as individuals is also changing. So we're changing our approach to using digital health. So you have to, it has to be real world evidence, and it has to be a longitudinal study, not just a single moment in time.
Because you're actually measuring, as you quite rightly said, you are not licensing something for day one, which is going to be identical to day 356 or whatever, but you're licensing it for the life course of the whole process.
Exactly.
Intellectually, that's difficult to comprehend.
It is. I think, you know, this is a big part of what we get obsessed with at ORCHA, which is about pathways and understanding what technology different people need at what point in the pathway. And I'm going to give you a personal example. So you know that I live with type 1 diabetes, and I had very late onset of that. I was 30. But what I needed from a technology when I was 30 was very different to what I needed when I got pregnant or getting pregnant, during my pregnancy, post, and then as I've become more mature in my understanding and management of myself, what I want now is very, very different. I want data dashboards that can pull in information and help me to manage my blood sugars on a day-to-day basis. So the product that I want changes. Now, the insulin that I use has pretty much, I have changed my background insulin, but I've probably still been on that now 5 or 6 years. And the Nova Rapid I take has been the same since day one. So it's just being really clear. And of course, as clinicians, we understand that all then needs to be directed back to clinical evidence base. And the evidence of a product should be able to indicate not only is this effective, but who is it effective for at what point in their journey.
Yeah, and you also mentioned real world data, and we've had some real challenges in getting real world data accepted as being relevant.
Absolutely.
Because, of course, by definition, practically, real world data is to a large degree about association. And we constantly hit this wall of causation, not association. This is not robust or relevant enough for me to include it within my armamentarium of evidence. Yes. But I think those discussions, to a degree, fortunately, I think we're sort of getting over them. I really do.
Because I've got to say, I'm hopeful. That's my word. I'm hopeful that we are progressing.
Yeah. Are you hearing
learning? This? Absolutely. Good. It's been slower than I would have hoped or expected. But everything always is, and I'm extremely ambitious and probably a little bit positive in my attitude on a lot of occasions. But I think that it's really, so if you look at some countries, Germany have been absolute pioneers in this
Well,
space.
with DIGA, of course, yes.
They've
Let's
been
talk about DIGA a little,
of
because
course.
we need to talk about DIGA a little. So could you just sort of give your, well, let's first define it first. What is DIGA? And I'll let you say it better than me.
Of course. So in Germany, and I think they have been pioneers, there have been some challenges, as with every pioneer, but they have been pioneering. I don't want to take that away from them at all. So what Germany said was they wanted to set a criteria for the assessment of digital health technologies. They were predominantly focused on medical devices, and they said that over the first year, they would process products through an assessment process, which is run by BayPharm. They would assess to DIGA, and anything that passed the DIGA criteria would then receive a stamp, a DIGA stamp, and go into a repository. They also then passed a law that said if a doctor recommended a DIGA compliant product to their patient, that the health insurer has to pay for it, and they passed the law. And that's the pioneering element of that. Is what they did was they linked quality and compliance to reimbursement. And that was incredible. So the market, that was a huge market signal to digital health suppliers globally to say, we're open and we're interested in using these technologies for our populations. Now, I'm just going to continue my story, if that's all right. So this started about 2.5, maybe 3 years
ago now. Yeah.
And what's happened is the first thing to say is on the criteria excluded in the first instance clinical evidence. So the process suggested that over the journey of a year, that product could generate its clinical evidence, and then it would have that evidence. And again, that sounds like not an unreasonable thing to do. However, the consequences of that were that, of course, as a doctor, would you recommend something to your patient that hasn't got relevant clinical evidence? So, of course, what that meant was that doctors said, I'm not recommending something that isn't clinically evidence. And then the health insurance said, I'm not paying for something that hasn't got clinical evidence. So that was the unintended consequence of that decision. Now, what then happened was that those products then weren't recommended as frequently as the business expected. And of course, they'd invested a lot of money getting into this market, going through the DIGA process. And then you fast forward a year, they've not generated enough clinical evidence. And of course, the price for the product then is reduced because that clinical evidence hasn't been able to be proven. What that has meant is that a number of companies have then struggled to stay in the market. In fact, a number of them haven't stayed in the market. So I think the learning from all of that, is that you have to think through the unintended consequences, and you also have to think through the whole system and the whole distribution channel. The other thing was that a lot of doctors in Germany had never even heard of DIGA. A lot of doctors still haven't heard of DIGA.
Well, Germany is in a particularly interesting space in terms of digital health, as we know. I mean, there isn't even an EMR in Germany, in essence, because, of course, Germany is a whole series of small Landen.
Absolutely. So I think the learning now, and they have been pioneering, I genuinely don't want it to sound anything other than that full respect, but just learning from those unintended consequences for the next country. So we see France now saying they want to adopt something similar. But what I'm seeing is that they're starting to learn from some of those unintended consequences. So this is when I get really hopeful. Now, what I really want to do is speed up that learning, because we know what the unintended consequences are. We know that we need a whole system approach in the same way that we have for pharmaceuticals and drugs. So you wouldn't just have, in this country, MHRA and NICE checking to see if a drug is safe and effective, and then that's it. you have a whole infrastructure where doctors are trained in these drugs. You then have access to systems and processes that enable you to pick and prescribe, and there's a reimbursement. So just thinking through that system and thinking through, okay, well, how are we going to deal with that in the world of digital health? And by the way, the bit that everybody always forgets about is at point of receiving a prescription, you go and collect that from the pharmacist in this country. And if you've got a question, you ask them and they can tell you how to use it. So even if a doctor recommends a product to you, you may still need educating in how to use that product. Can't forget about that.
Well, and I want to pick up on that because you mentioned the difficulties digital health providers have in receiving payment associated. Now, I, like you, am full of admiration as to the logical way in which DIGO was actually set up. I think this is exactly the way one should do it. I part company with you, however, when you say that unexpected consequence is something one can predict, because in complex adaptive systems, and by God, is healthcare a complex adaptive system, you always get unintended consequences. I could spend the next 6 years talking to you about unintended consequences within my experience. So, you know, that is something which will always be a little bit of a surprise.
No, and I don't disagree with you. I think my reflection is that before Germany started these processes, other countries had also experienced some of those unintended. That's where the shared learning comes in. How can we learn so that those unintended consequences are not duplicated over and over again, and actually move the dial forward?
Yeah. But then if you go to the US, there have been various failures of large digital organizations, some of which associated with the fact that when individuals were given a prescription for, and I hate the term, but it's the word we use, prescription for an application, some people didn't bother to pick it up, and hence the insurer didn't think it appropriate to pay for it, or there were discussions, debates, and differences of view as to when payment needed to be effected, when somebody picked something up, or when somebody completed a course, or and we've, you know, the equivalent would be, if we think in terms of therapeutics, how many people complete a course of antibiotics? Just something very simple. And the answer is not as many as we think. Does that mean that we do not pay anybody until they complete the course? Well, we don't do it that way.
No, absolutely.
And you know, with digital health.
Exactly. Hey. And I think that you're hitting on a critical point, which is people, that there seems to be an expectation in digital health that it's perfect and that there'll be 100% adoption and that the outcomes will be achieved for everybody. We do not expect that from any other therapeutic intervention, be it a drug, be it therapy, be it in person, you know, mental health, talking therapies, whatever it is, we don't expect that. So if you take something like obesity, again, I'm just going to use data from England, it's about 50% DNA rate did not attend. 50% of people don't attend that obesity clinic. But when we deploy a digital health technology to support somebody with obesity, there is an expectation that 100% of people will adopt it and that the impact will be felt by every single person. And that can't be the case. So I completely agree with you. I think that we need to reset our expectations and reset what we currently are achieving, and therefore what could be expected in the world. And this is where that real world data comes in. It is so fundamental and so critical.
Yes, agreed. So let's think a little bit forward now. You know, how are we going to address adoption at scale here amongst health systems? We have some exciting things happening. I want you to talk about them. The ISO, label to enable, that sort of stuff.
Yeah, absolutely.
So take this out. This is important.
Absolutely. So I think globally and pan-Europe, there has been, people have got, or countries and governments have got stuck on working out what is the criteria for a successful, a trustworthy digital health technology. And unfortunately, there's been a lot of money gone into building that criteria and spending time on building the standard. My personal opinion is, until somebody uses and benefits from said evaluated technology, we've just done an interesting academic study. So what the ISO, the label, there was a new ISO 82304 Part 2, was created a few years ago. And the ISO was meant to create a set of criteria for the whole of Europe. Then there was a European project which was funded by the Commission called Label to Enable. And the Label to Enable project was meant to take that ISO and start to apply it practically to assess technologies, to build in systems and processes, with the idea that ultimately at the end of this Label to Enable project, we can operationalize and have a label, a certificate that everybody in Europe or even wider can use to say, okay, it's gone through this process. It's now got the label, therefore I can trust it. And what does that mean? Well, it means then that everybody can then get on with distributing safe technologies, directing people to safe, effective technologies, and enabling healthcare systems and professionals to pick and recommend the best and put them into clinical care. So where are we at so far? We're about, the Label to Enable project will complete this summer. And you can go to the Label to Enable website. If you just type in Label 2, the number 2, Enable, it will come up, and you'll be able to see all the different work packages. What the consortia are now doing is looking to operationalise this so that certificates can be released in a very scalable way. Governments can either adopt the scheme wholly or align themselves with it. So there's a lot of the ISO which is relevant in DIGA. I'd probably say there's, I mean, I'm a little bit guessing here, but about 80% similar criteria, the same as PCAM. So the idea is that, of course, you may have some different criteria, but what that means is, as a supplier, you can go through the bulk of it once, and then you can say, go to BayFarm and do the enhanced element for achieving DIGA, but everybody can then get on with investing in the distribution, activation, and reimbursement. That is fundamentally critical, because suppliers will engage with this compliance criteria and invest in it if it links you to reimbursement. And that's why we saw so many companies and suppliers go to Germany. We're seeing the same in France because of PCAM. We're seeing inward investment. It's great for the economy as well as health outcomes. So what the Label to Enable project is trying to encourage everybody to share in that knowledge so we can get on and invest in the right side of the equation.
Which is exactly really where we end to a degree. There's one thing we still need to talk about, really, where we said the issues were around reimbursement, around speed of reimbursement, around model, around consistency. So I think we're getting to where we need to.
Yeah.
But before we finish, I think it's important we talk about the new digital health pathway in cardiology. We have an association, of course, with the European Society of Cardiology, who are co-designing the program with us in Helsinki. And there's some quite exciting news.
Absolutely. So I think I mentioned earlier on in our conversation that when ORCHA are assessing and evaluating technologies, we're not just looking, do they meet this criteria, but we're also really delving into the evidence base to say, who is this effective for at what point in the pathway? And then we take those single point evaluations and drop them into a pathway. So a pathway, when we're talking about cardiology, doesn't just start with people who have had a heart attack. It starts with preventing that heart attack, diagnosing, assessing, finding these people to stop the heart attacks. Of course, there will be certain people who are more at risk of a cardiology challenge. So how do we support those people? So what we've done is look at the use case and the journey that people go on, and think about, well, which technologies can help which groups of people at what point in that journey. And of course, the word pathway is used, but the reason I'm just slightly adopting it to journey is because a pathway quite often means that you're having a touch point with a clinician, and part of this journey is well before you even touch a doctor or a nurse. So thinking through that whole journey and then thinking about, well, who does that person have a touch point with? And therefore, who's the best person to recommend that technology and activate that person to use it? So it may be a health check. That may be a good touch point for certain healthcare systems. It could be when you go to it could be when you're going for your diabetic health check. I've shared with you that I'm diabetic. That could be another good touch point. It could be any of those points.
It could be even earlier, Liz.
It could, absolutely.
As we are developing our thinking, and of course, the overarching theme of the Radical Health Festival is radical. And the radical bit is associated with us thinking in terms of primary prevention for populations. So we're talking about people who are nowhere near.
Absolutely. So I 100% agree with you. So, I mean, I would love to see the day when, so I'm sure that everybody has been into a phone shop, O2, EE, whatever. I'd love to see the day when you're in there, that the provider of your mobile phone, your smartphone device, is able to say, did you want me to add on, in the same way that I get offered when I upgrade my phone, oh, you can pick one of these apps to go on and we'll give it you for free. Yeah. Let's ask them, do you want an intervention to help you? What's the health challenge that you're currently experiencing? What do you want to achieve? And it doesn't have to be a doctor, a nurse, a teacher. Just think about
to do that.
Yeah,
perhaps a little bit too early. I know a supplier in Canada that tried to do that, and I think it was about 15 years ago.
Right.
And wow, they didn't get very far, but 15 years ago, there wasn't very far to go.
No, exactly. And, there's also employers. Employers are actively wanting to keep their workforce healthy and well for obvious reasons. So you're absolutely right. The radical side of this is, how do you engage with the wider community, religious leaders? That's another area that I think, we talk about hard to reach. People are not hard to reach. It's just that we're not supporting where they go.
The door is. We have to find the bloody door.
Yeah. So, and ORCHA are absolutely obsessed with that activation. The best way to activate somebody to use a technology is that a trusted person recommends it, and that trusted person doesn't have to be a doctor.
Absolutely wonderful conversation, which we started, which we will continue at the Radical Health Festival. So thank you very much, Liz, for taking the time to have a conversation today. I really quite enjoyed it. I learned a little bit as well, which is good news.
So did I. And thank you very much for inviting me to speak with you. It's been a real pleasure.
So thank you. And we meet again very soon.